Hi, you are welcome to this session. We'll be discussing Gynatresia. My name is Muniruddin Aderemi Ijaya. I'm a professor of obstetrics and gynecology and consultant obstetrician and gynecologist and fistula surgeon. I work at University of Ilorin and University of Ilorin Teaching Hospital, Ilorin, Kwara State, Nigeria. Gynatresia is becoming common in the developing countries as a result of non-patronizing of orthodox health care facilities. The learning objectives. By the end of this module, the learners are expected to be able to list the causes of Gynatresia, describe the different clinical presentation of Gynatresia, and explain treatment modalities of Gynatresia. So by way of introduction, Gynatresia is becoming more commonly encountered in practice as a result of increasing level of poverty, ignorance, and non-affordability of healthcare services in developing countries. It is defined as narrowing of the female genital tract or obliteration of the vagina. There are two categories. You have the congenital one and the acquired one. Congenital types are fairly rare, and these are the congenital causes. You have the imperforate hymen, vaginal septum, which can be either transverse septum or vertical septum. The vertical septum defect is from vertical fission defect, which is from incomplete canalization of the vagina or failure of fission of the Mullerian system with the genital sinus. While the vertical septum is due to failure of lateral fission of the Mullerian ducts. Then we also have the vaginal atresia, which we see in Rokitansky syndrome, is as a result of failure of vaginal plate formation. Complete androgen insensitivity syndrome, also known as testicular feminization syndrome, is another congenital cause, which is genetic related. The acquired causes, we have the female genital circumcision, which is the leading cause. It can also occur in fistula, genital fistula, or post-fistula repair, where there may be reduction on the vaginal capacity from fibrosis. Vaginal fibrosis and scarring, complicating obstructed labor where there is no obstetric fistula associated with it. So in this situation, there is ischemic vaginal wall, which provokes adhesion and scarring. It's also becoming common use of corrosive substances, inserting corrosive substances into the vagina. And there are various herbal products now for treating infertility and fibroid. Caustic soda too are also used to procure abortion, and sometimes they are also used for vaginal tightening and to enhance sexual pleasure in postpartum women. Gynatresia can also occur following birth trauma, either from a healing process, fibrosis from healing process, or after repair of birth trauma. Radiotherapy for gynecological cancers can also cause Gynatresia. Then we have chronic graft versus reaction, then insertion of foreign body into the vagina can also cause Gynatresia. How do they present? The presentation depends on the cause, and the time of presentation also varies. Some present at childhood, puberty, some later in life, some during labor, and some of them are just incidental findings. So at childhood, few patients with infibulation may present. At puberty, when somebody is expected to menstruate and they are not menstruating. After some years, they still remain amenorrheic. Some also present with cryptomenorrhea, especially people with obstructive type, like a transverse vaginal septum, imperforate hymen. This one may present with cryptomenorrhea. Patients with Rokitansky syndrome, where there's vaginal atresia with rudimentary uterus or absent uterus, they present with uncomplicated amenorrhea. In situations where there's functional uterus with vaginal atresia, they also present with obstructive complaints. They have cyclic abdominal pain and cryptomenorrhea. Complete androgen insensitivity syndrome, testicular feminization syndrome. This is genetic disorder. The parents they have a karyotype XY. They are male genetically, but they are female phenotypically. There's breast development. They have normal external genitalia, but the vaginal depth is of different length. So usually the vagina ends blindly. They have sparse or absent pubic and axillary hair, and they present with amenorrhea at puberty. So diagnosis is usually made around this time. So at adulthood, some of them that go beyond the time of achieving menstruation, they may present with coital difficulty. Maybe there's difficulty with penetration. Some present with dysmenorrhea, and some may complain of infertility. For the longitudinal septum, it can be in form of obstructive type or non-obstructive type. If it's non-obstructive, they may achieve coitus without much difficulty. Some may have dyspareunia, and some may even conceive and present in labor. It may be detected during labor. When you do vaginal examination, we are going through the one that is leading to the obstruction, or that is obstructed, or the one that you cannot get access to the cervix to, or that is the time you now find out that there are two canals. That is what you have in some situations. Transverse vaginal septum, if there is a little opening too, it may not be obvious until maybe during labor, when they present with obstructed labor, when they present in obstructed labor. For acquired causes, one may be able to get history relating to the etiology from them, history of insertion of chemical substance into the vagina. There may be past history of obstructed labor that leads to scarring, or history of past history of endotherapy. For those that are using corrosive agents into the vagina, they may not disclose early, so one has to probe very well, forget the information. Examination. General examination is important. Look for secondary sexual characteristics. Abdominal examination, you will be able to feel the suprapubic swelling, which may be a pointer to hematometrium. Vaginal examination, examine the pubic hair distribution, whether it is normal or the pubic hair is scanty or absent. Examine the hymen for the development and the external genitalia, the vaginal length. Also look for vaginal septum, the hematocorpus. All these are what one you look for when one is doing vaginal examination. Rectal examination assess the pelvic organs. You may also be able to feel the hematocorpus. How do you investigate? You do the general investigation, full blood count, Renal function test is important in this situation, especially the congenital types. In about 30 to 50% of congenital genital abnormality, there is associated urological abnormality. So renal function test is important. You do IVU as well to show the kidneys and the ureters. Sometimes there may be pelvic kidney. Another urological abnormality may be detected from IVU. Urine microscopic content sensitivity and urinalysis are also important. Pelvic ultrasound, so I said the pelvic organs and the kidney, and sometimes there may be need for laparoscopy to look at the pelvic organs. Treatments for the imperforate hymen, crustaceous incision and excision of the flaps is what is done. For the mild acquired gynatresia, simple vaginal adhesiolysis by blunt dissection and vaginal mold insertion is appropriate. Vaginal septum too, you do excision of the septum. If it's a thin one excise it, likely the blood vessels secure hemostasis, and that is enough. But if the septum is thick, let's say 1 centimeter, after the excision, you now oppose the upper edge and the lower edge together and secure hemostasis. But if it's wider than that, there may be need for use of graft to fill the space. But that is not very common. Management of vaginal agenesis with non-functioning uterus. Patients with congenital vaginal atresia need careful psychological counseling because it comes as a shock to the patient and her family that she has no vagina. This may be followed by depression and suicidal tendency. So there is need for reassurance, repeated counseling by a trained psychologist or somebody who is expert in providing counseling. This is to achieve adequate and fulfilling sexual life after surgery. Frank technique is used for patients with short vagina, and preferably vaginal length should be not less than 1 centimeter. This gives good prognosis. So it is used in complete androgen insensitivity syndrome. It involves manual dilatation of the vagina for up to 6 to 12 months. The pressure is applied to the vaginal dimple for 20 minutes twice daily. And this is done for about 6 to 12 months. So one starts with a small dilator and increases it gradually. It has a good success rate, as high as 90%. Makindo operation. This is used for it's an extensive surgery for severe cases. Here you are trying to create a vaginal pouch, a vagina, so to speak, between the urethra and the rectum. So an incision is made on the vaginal dimple, a transverse incision. So the space is created in soft areolar tissue between the urethra and rectum. This space, when it's creating, should be wide enough, wider than the normal capacity of the vagina, because during recuperation, the vagina will constrict a little, so that there won't be a problem of recurrent gynatresia or dyspareunia when the patient is having a sexual intercourse. So it should be wide enough. Then one should secure hemostasis. The depth should be as far as possible till you get close to the peritoneum. And after that, the plastic surgeon will cut skin graft from the anterior aspect of the thigh, that's the flexor surface of the thigh, and put on the mold. This mold is now inserted into the vagina for about 3 months. So there's a collaboration between the gynecologist and the plastic surgeon. The next operation is Williams operation. This is rarely used these days, though it still has a place where dissection of the new vagina is impossible. But as a criteria, the labia majora must be normal. Labia majora must be normal as a criteria. So in post-radiotherapy patients and a post-surgery patient who have a short vagina, this procedure is indicated. The principle is to create a copulation pouch. So what one does is to make a horseshoe-shaped incision or U-shaped incision, starting from the vulvet and goes upwards and forward, just internal to the airline of the labia majora, up to the level of the urethra meatus. And the edge of each wing should be about 4 centimeters lateral to the urethra meatus. The incision is deepened to superficial perineal muscles. Thereafter, we now bring the inner edges of the incision together and suture with interrupted absorptive suture over a mold. This is to serve as a guide to maintain adequate capacity. Then the second layer of suture of the same material is going to be used for the subcutaneous fat and perineal muscle. This is to reinforce the first closure. And lastly, the outer layer of the skin are also closed in similar fashion. So post-operative vaginal dilatation is done twice daily. The advantage of Williams operation is that it is simple to perform and patients stay for a short time in the hospital. The drawbacks include psychological problems of distortion of the external genitalia and alteration of the vaginal axis. This is a major concern to patients. Other treatment options modalities for creating new vagina were Kratzer's modification of Williams vaginoplasty, Watson-Cherry's George method of operation, and Facchetti procedure. Total laparoscopic segment vaginoplasty is another treatment option. So we've looked at definition of Gynatresia, the various causes, both the congenital and the acquired causes, their presentation and management options. So in conclusion, acquired Gynatresia is becoming common in developing countries. The government and professional associations should take necessary actions, such as sensitization programs, improving socioeconomic condition of the populace, and implementing health for all scheme to put a stop to this ugly trend. Many cases of Gynatresia requires multidisciplinary approach, and the severe cases need support from the time of presentation through diagnosis, decision-making, treatment, and follow-up period. These are the references. Thank you for listening.